To conclude this free presentation, I would like to ask to Dr. Gonzalo Bernabeu from Madrid, Spain, to give his talk that should spread some concept about patient selection and the good strategy to adopt trifocal technology. Please.
Thank you. First, sorry for my English. It's not as good as the rest of the speakers, but I'll try to do my best. Okay, and I'm going to speak about the selection criteria for premium patients with Ray 1 trifocal, but it's for me with all the trifocal lenses. My experience with multifocal lenses is more than 1,000 trifocal lenses implanted in last 6 years, only for myself, not for my team. We have more lenses implanted, 0 explanted lenses, but more important, 0 unhappy patients. For me, it's very, very important, the selection of the lens and the selection of the patient. 42 Ray 1 trifocal lenses implanted. Today, my first choice in trifocal lenses. I'm very happy with this lens, very, very happy. Very high patient satisfaction. And with Ray 1 trifocal patients, they don't talk about halos. If you ask the patients, they say that they can see the halos, but they don't come to the clinic talking about the halos. Only one patient is a special patient. He told me about the halos, but he tolerates perfectly, and he sent me another patient, so probably he's happy. No? Nowadays, the industry manufactures very good products, but we can have a big problem if we implant a trifocal to the eye of wrong person. When a well-operated patient with multifocal lenses and emmetropy is unhappy, usually because of a mistake in a patient selection. So we must ensure perfect patient selection. This patient, the patient with multifocal lenses, has to be seen from 2 different points of view: medical, study the eye, and psychological, study the person. For me, this is very important. The great problem of the multifocal. For me, multifocal lenses are not bad. There are only bad patients not suitable for multifocal. No? And this is for optical reasons. I'm talking about the eye. And about the person, visual reasons, psychological reasons, and labor reasons. Optical reasons, patient with refractive surgery. I implant multifocal lenses with refractive surgery, but we have to be careful. No? Dry eye, this is, for me, this is impossible for multifocal lens. No? I saw this patient, and another doctor wanted to implant a multifocal lens, and with this cornea, it's impossible. Dry eye, be careful with the dry eye. Pseudoexfoliation is very important, the centering of the lens, in glaucoma, in maculopathy. For this patient, for me, no implant a multifocal. No? In visual reasons, I'll talk about this kind of patient. You are in the refraction room, and patient that you put only 0.25, and the patient says, "Oh yeah, very good." And he feels a small difference, no, in the refraction. This patient, to be happy, he needs a perfect emmetropy. With a small refraction defect, the patient is not going to be happy. No? This is because some patients have this TB in his brain, but another patient have this, another patient this. And for me, there are patients with 4K brains, no? 4K resolution. And the resolution in the brain is different for some patients. And the patients with 4K brains are difficult to be happy, no? Because they feel a little difference, and you have to see that. Psychological reasons, persons like this, you know, if you put a multifocal lens with these patients, you are going to have a problem. And you have to see, I have patient, the wife and husband, and I put a multifocal 1 year ago to the wife, and the husband comes, I want the same lens because my wife is very happy, and I say, no, not for you. You are angry all day because, you have to see that. Some patients are not for multifocal. And labor reasons, no, is with high definition jobs, night drivers, pilots, is difficult, no? You have to speak a lot with the patients. So which is the best lens? I think it's an incomplete question, is which is the best lens for this patient? It's very important, no? With a multifocal lens, it will be perfect for far and near vision. You can see a bit of halos at night, but this is perfectly tolerable. It is the lens that you need. You will be delighted and perfect. Go with my secretary that she gives you the budget. Perfect, 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 perfect. Avoid the word perfect. I think it's enough to be good. Perfect is for people with 20 years old. Sometimes the patients are perfect, but good is enough. This is the patient looking for the perfection that the doctor promised him, no? And he's looking for the perfection, no? And the patient is only good. The patient, okay? But without you, nothing makes sense. It's very important, good technology. Okay, we have good lenses, but we need good technology to make the measurements, and good people, good personnel with us. It's not the same biometry with this man that with this, no? And it's very, very important. This. And for me, it's very important to have a LASIK. If you promise a patient be independent of glasses, and you have a small defect, a half diopter, 1 diopter of astigmatism, and the patient feel that and he's uncomfortable, you need a laser to have a solution, no? And I want to speak about the Pentacan and cataract. For me, this is very important because we can't forget the cornea. If we implant a multifocal lens, check the multifocal cornea. It's very important, the cornea, no? The power distribution analysis of the multifocal cornea, when we have all the power of the cornea in a small interval, this is a good cornea for a multifocal lens. But when we have a cornea like this, you have big difference in the cornea. For example, this is a radial keratotomy. It's a corneal impossible for a multifocal because the aberrations are going to be very bad for the patient. No? This is astigmatism, and in the astigmatism, regular astigmatism, you have two peaks. And this is astigmatism, good for a toric trifocal lens. But when you have difference between the anterior surface and the total cornea astigmatism, like this can be a problem for a multifocal. No? Talking about the quality of vision, no? It's very important. It's not only the quantity, it's the quality of vision. And here we can see difference between the anterior surface and total corneal keratometry. Cataract pre-op screen for premium lenses in Pentacan, its main clinical use is the preoperative evaluation of the optical properties of the cornea for the selection of premium IOLs using a 4-step approach. Evaluation of corneal irregularities, evaluation of the corneal shape, evaluation of corneal spherical aberrations, corneal astigmatism evaluation. The first step is evaluate the regularity of the corneal topography and compare the axis of the anterior face and the total corneal refractive power for the implantation of toric IOLs. Toric, monofocal or multifocal. No? We have to see the axis is the same in the anterior surface and in the total corneal refractive power. Normally, when I put a toric trifocal lens or monofocal, I see more the total corneal refractive power axis, okay? And the second step is comparison of powers of corneal astigmatism for indication of toric IOL to see if there is an important difference between the astigmatism in anterior surface and total corneal astigmatism. It's important to calculate the lens. The third step, total spherical aberration for the choice of spherical or aspherical IOLs. The multifocal lenses have little difference between the lenses. Right one trifocal lens is a neutral spherical aberration lens, and when this value, total corneal sphericity, is higher than 0.3, 0.4, for me the election is a lens with negative spherical aberration. But in a normal cornea, the right one trifocal for me is the best lens because it's neutral. This is the different spherical aberration. And the fourth step is the total high order aberration. Be careful when the total corneal, the high order aberration is higher than 0.3, and 0.5 is very, very dangerous in plana multifocal. No? This is to see the total corneal irregular astigmatism of high order aberration is more or less is how irregular is a regular astigmatism. Okay, a patient with regular astigmatism, how irregular is the regular astigmatism? And this is important for a multifocal lenses also. This is a good patient for multifocal IOLs, and this is a bad patient, no, with high aberration and with a power distribution bad for multifocal. And for finish, the kappa angle in some patients is not tolerated multifocal if the kappa angle is very, very high. And tips for entrepreneurs in multifocal lenses. Remember that patients will always feel more comfortable in binocular vision. It's very important that with monovision only in one eye. Beware of low myopic patients. They are very, the near vision was very good. When we offer something, you have to know what they had before. Keep in mind the pupil, attention in prior refractive surgery patients. Very important that the patient feels that he choose it with us. The doctor gives the information, can advise, the patient decides. Always leaves an open door where he feels that he can choose the monofocal lens. And patients should not feel pressured with only one option. Don't let yourself be taken because the patient asks for it. Doctor must know how to choose the best for each eye and for each person. 20 minutes before can save us 20 hours after. Nothing that embeds the human is as good as we have in our body by nature. And don't sell perfection in such a way that the patient choose the expensive lens. Be careful with that. Try to know the patient in those few minutes and mark real expectations that don't face the unknown. Many patients come happy to a second opinion because they are only okay and told them that they were going to be perfect. Okay? And to finish, right one trifocal is the lens with less light energy loss, is the lens with the most energy distributed for the far focus, good also for its design for small capsular bags, preload entering without problems, neutral, perfect aspherity in patient with hyperopic LASIK. In the postoperative period, consider the myopia in the autorefractometer between minus 1.75 and minus 2. That is emetropy, okay? Thank you very much.
Thank you. Thank you, Gonzalo.